I am Graham Virgo and Master of Downing College, and I am delighted to welcome you all this evening to this lecture. Thank you for coming, particularly those of you who've come from some distance. Everybody is welcome, but particularly those who've come from some way away. Tonight's lecture marks the beginning of a collaboration between Downing College and this institute. Downing College has a long-standing tradition of excellence in medicine, in law, and the sciences, and its work aligns closely with the work of this institute and make us natural partners, particularly because one of the things I want to do as master of this college is bridge the gap between academia and policy. And that's why it is especially fitting that we are hosting this evening's lecture, Can Improvement and Innovation Save the NHS? And I'm delighted to welcome Professor Mary Dixon-Woods, Director of this institute, and the Health Foundation Professor of Healthcare Improvement Studies in the Department of Public Health and Primary Care at the University of Cambridge. Mary is a leading figure in healthcare improvement and patient safety, whose research has had a major impact on the quality of health services. She is a fellow of the Academy of Social Sciences and the Academy of Medical Sciences. She's an honorary fellow of the Royal College of Physicians, the Royal College of General Practitioners, and the Royal College of Obstetricians and Gynecologists. She was also awarded an honorary Doctorate of Science by the Royal College of Surgeons of Ireland. Mary served on England's National Advisory Group on the Safety of Patients in England, which produced the Berwick Report in 2013. She also served on the review of information technology in the NHS, led by Professor Bob Vactor, which reported in 2016. She was a Wellcome Trust Senior Investigator from 2012 to 2019. Mary was the Harveyan Orator for the Royal College of Physicians in 2018, the 500th anniversary of the college's founding. And she is a member of the BMJ's International Advisory Board. It is a genuine honour to have Mary here with us this evening at Downing. And please join me in welcoming Professor Mary Dixon-Woods to the stage. Thank you.
Many thanks indeed, Graham, and can I add my thanks to those who have travelled to be here this evening. This institute is a unique centre that addresses the need for high-quality, scientifically grounded and crucially impartial evidence to guide improvement and innovation. It also innovates in the methods for meeting these challenges, and it's characterised by its very highly participatory approaches. There's a pressing need for such a centre because the NHS faces many problems. I'm going to give you a sample. Not all care is accessible. Access to general practice and A&E waits are the public's top priorities, but satisfaction has been falling for a long time. Not all care is timely. Waiting times for elective care have been a problem for over a decade, and again is a huge public priority. We are seeing ongoing delays in initiating treatment for cancer, where the targets for timeliness have not been met since 2020. We have a situation where not all care is of good quality. Everyone living with diabetes, for example, should have 8 key care processes completed every year. At the moment, that happens only 43% of the time, and we also have a pattern of massive variation across integrated care boards. 1 in 5 trusts have a reoperation rate for breast cancer greater than 20%, and that again demonstrates a pattern of huge variability. 1 in 14 patients in some trusts will undergo reoperation, indicating that the first one was not successful, to 1 in 3 much more successful in others. This is high risk, and it also consumes an awful lot of resource. Not all care is effective, and we also see that some effective treatments are not given, and that this is patterned by socio-demographic inequity. We have suboptimal care that contributes to and compounds inequalities, including those relating to cancer and cardiovascular care. At the same time as we have ineffective care, effective care not being given, we have a pattern of ineffective care. So some low-value interventions continuing to be used. We're seeing a massive uptick in the number of diagnostic tests since 2010, but many of those requests are not compliant with guidance, and it is inappropriate. Not all care is equitable. If we look at waiting times, for example, they are worsening overall. But where you live affects how long you wait, and that variation across ICBs is increasing. We see inequities by geography. For example, if we look at regional variation in waits for diagnostic tests, while there's a median of 3.4 weeks, that ranges from 2.9 to 4.1. We see horrendous inequities in maternal mortality, where we've had a shocking increase, 21%, but black women are more than twice as likely to die. And women in the most deprived areas die at 3 times the rate of those of the least deprived. We see a pattern of severe morbidity, patterned by deprivation and ethnicity, and the data suggests that improvements in care, this isn't looking at demographic variables, could have made a difference in around 45% of cases. We see stillbirths demonstrating exactly the same pattern of deprivation being strongly associated with the risk of a stillbirth. We also see that gender plays a role in inequities. Women are less likely to receive a brain scan within an hour of onset of stroke, and our collaboration with the Royal College of Anaesthetists has also identified that women wait longer for emergency bowel surgery. At the same time as we can identify many of these patterns, some of the most important variables remain poorly recorded, so we can't actually tell what's going on, including variables relating to ethnicity and socioeconomic disadvantage. And in areas such as dentistry, which plays a very important role in the health of the nation, we have almost nothing. At the same time, not all patients have good experiences of care. While 3/4 of patients have a good experience of overall experience of general practice, 1 in 8 have a poor overall experience. And again, we see that concerns about access to general practice are extremely prominent. If we look at urgent and emergency care, we see a quite low proportion having a good experience, and again, about 1 in 8 having a negative experience. If we look at things like inclusive communication and shared decision making, that does not happen reliably, with people describing how they felt they were made to feel unimportant and not listened to. Sadly, staff report that they also don't have a positive experience of work reliably. Many do, but some don't. And when we have looked at, for example, the experience of the workforce, there are multiple influences on why staff are not having a good experience. Some of it is that the organisation of work does not support satisfaction, it's not rewarding. Time is spent in activities that appear to divert from giving good care, and unfortunately we see patterns of bullying, racism and harassment that have remained sadly uncorrected. Not all care is safe. Patient safety remains a major challenge for the NHS. We are spending about £5 billion a year in compensation costs for harm that by definition, because it's payments for negligence, could have been avoided. And every pound paid out represents human suffering. Every pound paid on clinical negligence is also a pound diverted from care. It's the same budget that is paying for the harm as is paying for the care. A bigger pattern here is of organisational degradations, where we see a repeating pattern over the decades, going back to one of the first scandals in March 1969, to ongoing and repeated scandals and inquiries, where it often feels like the only thing that is changing from one to the next is the font. It's the same issues coming up time and again. We have this all in a context where productivity challenges are increasing the pressure on the NHS. In the UK, about 1 in every 5 government pounds goes on health. So it is a major source of government spending, but a sense or a growing threat that productivity is not keeping pace and that the NHS could become unsustainable. And we see this repeated in policy documents. Penny Datch's review from last year on the patient safety landscape, for example, pointed out more than once that there has been a huge increase in, for example, hospital NHS staff. The proportion of doctors and nurses has increased. There's been a 25% increase, but we're not seeing the same improvements in safety and productivity. So the Health Foundation have identified that sustained improvement is essential to long-term sustainability, and that an extra 1 percentage point of productivity growth over each year of the next decade could free up a lot of money, but failing to do so would leave a big dent in public finances. So we have problems. How do we do better? That's where I want to focus today. You'll be glad to hear. And I'm going to suggest to you that if you're going to improve, then you need a number of things. You need high quality evidence, and I'm going to show you why. We need participation and collaboration, and very importantly, we need to exploit the strengths and assets of a national system in a way that we have not done previously. Some of the best evidence we have about how to do improvement and innovation is for collaboration and participation. Those of you who enjoyed a nice glass of water before you came up here may have noticed these lovely pamphlets, and this is from a series that's been produced by this institute that summarises the best available evidence to support improvement and innovation. And what we know, and what we have consistently demonstrated in the work of this institute, is that if you work with people, you can make an awful lot of progress. Some of that work is always going to be in person, it's always going to be talking, it's always going to be getting together, it's always going to be bringing patients into the story. But increasingly also we need to exploit the strengths of digital solutions. And so we've been building platforms that enable people to come together online and collaborate in new ways. And increasingly we're using platforms that take advantage of some of the better qualities and the better features of social media, so people can join in conversations online and have debates and learn from each other in ways that are not possible other than with scale. And I will just mention that I'm a non-executive director of Discovery and the Meliorum Foundation, but I don't receive any financial benefit from either of those. This is all important because if the NHS is going to improve and innovate, it needs 3 capabilities. First, it needs to be able to characterise and understand problems. Second, it needs to be able to develop possible solutions. And third, it needs to be able to evaluate. And I'm just going to talk you through each of those. If we start with characterising and understanding problems, we need structured, systematic methods to describe what's happening and to explain what's happening. Some of that means that we need to improve how we are doing data and how we are measuring. We've already mentioned the problem of the clinical negligence bill. Much of that arises from perinatal brain injury. We are still in a situation where we have no single source of data on this. The definitions are not standardised across the sources that we do have, and the sources are not linked. If we look at perioperative care, surgery again being an important focus for quality, we see 615 different indicators, inconsistently defined, and very few patients involved in their development. The good news is that we have shown that measurement can be improved. So if we look at the perioperative care example, we can use techniques like literature review, bringing people together, collaborating, and we can come up with better ways of doing the measurement. Increasingly what we're doing is using online communities to do this, so we can collaborate with a group that works through a project, works through a problem together. And those methods have resulted in a quality framework for perioperative care, which identifies the different components of the perioperative pathway that need to be improved. And that has been extremely popular. It's been endorsed by the major national bodies, and we have now produced and I should say co-produced, co-designed a set of indicators of perioperative care that can be used as a single set for measuring care in the NHS. Counting and measuring is important, but it's only going to get us so far. If we're going to diagnose the problems, we have to be using multiple rigorous methods, and again, I will say this many times, participatory techniques and sound theories. And this is because the problems as we imagine them to be are not necessarily the problems that they are. A prize to the person who guesses which medieval animal this is meant to be.
Crocodile.
Very good. The prize will come later. One of the key insights of the improvement world is that if we're going to look at outcomes, you have to improve both structures and processes, and you need to understand both. We spend an awful lot of time in policy world talking about structure, and that's things like the facilities, the equipment, the staffing and so on, and that's all clearly very important. But we also know that not all variability can be explained by variability in structure, and that if you look at settings that appear to be very similar in terms of their staffing, their equipment, and their facilities, you will still find that there is variation going on, and that is explained by variation in processes, and that's the actions that are being taken. A very simple example of this is that if we look at rates of diagnostic imaging at trust level, that is not explained by structure alone. You see very wide variations between trusts with the same number of scanners. So that focus on process is extremely important. And let's look at an example here. We've already identified that access to general practice is a key challenge for the NHS. We have, with our colleagues from the Health Foundation, catalogued the hundreds and hundreds of efforts that have been made to improve access going back to 1984. Many of these are zombie solutions. They keep coming back and are effectively undead solutions. And one of the reasons that they don't appear to work is that we think that improving general practice is not all about increasing the supply of appointments. So there's a sort of simple equation going on here that doesn't actually satisfy the search for improved access. So that excessive focus is not addressing the realities of access, and it's not addressing the realities of access because access is structured through candidacy, and candidacy explains how people become candidates for care, influenced by multiple different ways in which they identify themselves as candidates and how they progress through the system. So as long as we continue to think about access to general practice as being a simple supply-demand equation, and we neglect these multiple influences on how people become candidates for care and how that candidacy process tends to disadvantage particular groups who then suffer from impaired candidacy, we are not going to solve the problem. Yet it's exactly that poor understanding of the problem that explains this poor fit between the proposed solutions, for example in the 10-year plan, and what patients and staff actually want. Again, if we try to explain some of the inequities issues, one of the important group, a very neglected group in terms of inequities, are those with serious mental illness. They have a very serious life expectancy gap. They die on average, as our systematic review showed, about 15 to 20 years before the average. And much of this mortality is linked to their physical conditions, cardiovascular disease and cancer being misdiagnosed or diagnosed late. So we need to understand why it is that this group doesn't get the care that they need. And we've been doing ethnographic methods with peer researchers to understand why it is, for example, that there may be issues with identifying physical illness in people with mental illness in emergency departments. And what we find is that candidacy theory plus the operational logics in these settings helps to explain many of the difficulties that then can help guide solution design. Again, if we look at understanding timeliness of emergency bowel surgery, again, this collaboration with the Royal College of Anaesthetists, participatory online methods that was very respectful and engaging of the ground knowledge of people who work in the system, and very informed by patient and public engagement, using this community-based approach. That helps to explain the timeliness of emergency abdominal surgery by engaging with people on their experiences of what happens in trying to implement the guidelines in practice. So when we ask people to explain what is going on using this engagement technique, we can see that a massive gap appears between the work as prescribed, this lovely linear pathway, and the work as it's actually done, which is much more like a lot of spaghetti. And that means that we can conclude that this kind of setup has all of the characteristics of a socio-technical system. You're never going to solve the problem as long as you think about it as just being a technical problem. And that work identified multiple weaknesses in process and shared understanding across this socio-technical system, also identified that those challenges are tractable to improvement and are likely to benefit from at-scale coordination. And again, working with the community helped to identify which problems should be prioritised for improvement, and that has then informed the solution, which is this set of principles for better communication for imaging along the emergency abdominal surgery pathway. Similarly, if we're going to explain safety challenges, about half of the value of claims for clinical negligence is for maternity, and this is because this affects people at the beginning of their life, and you're then faced with a lifetime of costs. Many of those can be traced to problems in detecting and responding to the baby who's deteriorating during labour. This has been repeatedly shown. We also know that process has all of the characteristics of a socio-technical system, but for years the solution has been trying to train staff in how to interpret CTGs. And what we have shown through systematic review is that that doesn't work on its own. But what does work is understanding the problem better using formal methods. And the methods we use here are human factors and ergonomics and social science. And we can structure our understanding through human factors techniques like the Systems Engineering Initiative for Patient Safety. When we have used this directly in maternity units, this is a study where we have looked at why is safety in electronic fetal monitoring so hard. What we find is that there are many challenges in these settings, multiple types of CTG machine even on the same unit, 3 different types of guidance on how you interpret the CTG, massively varying teamwork practices, and different and very often suboptimal process design. We also see that many of these poorly optimized processes pervade the NHS. Many mundane but essential processes have never been designed properly. This is a study we did looking at the kit boxes you use for managing postpartum hemorrhage. This is a situation where you cannot afford to waste a minute, you can't mess around, and yet what we see when we have looked at how they're packing the stuff you need to handle this emergency, it's extremely variable. This is 6 maternity units, 6 different types of kit, box versus trolley, different contents, and massive variation in human factors, good practice. So it can take you a lot longer to find the thing you need in one box versus another. If we look at explaining productivity, the biggest expense we have in the NHS is staff, but time use, what exactly they're spending their time doing, is remarkably poorly understood. And it's simply not the case that NHS staff are not working hard enough. It is the case that we have suboptimal systems and processes that result in time loss, frustration, safety challenges, and impaired productivity. Again, if we use formal methods to understand the problem, we've used time and motion studies, so we go and observe what is happening for an entire clinical session, and we can track minute by minute what is happening. GPs work incredibly hard, and an awful lot of their time is wasted on underlying poorly designed processes, system-level errors that account for an awful lot of their time. But that economy of time use remains largely invisible. The proportion of their time that they are spending on operational failures and compensatory labour is unaccounted for, and of course that acts directly back then onto access issues. The good news is that patients and staff can reach consensus on priorities for improvement. It was demonstrated in the emergency bowel surgery project, but also we have shown that you can do it for general practice as well. And the top 3 are really basic things like inaccuracies in medical records, missing test results, and difficulties with referral forms, all things that could be improved. If we look at explaining organisational degradation, here cultural, behavioural and competence issues are among the most challenging quality and safety issues. I summarised a lot of these actually in the evidence I gave to the Thirlwall inquiry last year. But some of the most important issues are to do with voice and why it is that speaking up is so hard. You met Graham at the beginning, and a wonderful session from last year's This Space is available on our YouTube channel if you're interested in hearing more about that. It's an area in which we've done a lot of research over the years, and we've shown, for example, that there is a huge difference between formal and informal organisation of voice. So the formal organisation of voice may involve procedures and processes, but that is very different from how people understand it on the ground and how they think it's going to work. But even with that, we find that families are marginalised from these processes of voice. It's very difficult for them to engage with and give feedback and ensure that safety issues are identified. A particular problem is how dark and deep some of these problems are and how difficult they are to give voice to. And this is a known problem. HR issues are among the most common problems that are voiced by staff in the NHS. Bullying, racism, incompetence, malfeasance, poor team dynamics are the most common things. They make up about 80% of what's reported to Freedom to Speak Up guardians. And this is supported by very troubling data from the staff survey and other sources. The bad apple one is one people don't like talking about in safety science, but it is a very real one, and I don't think we have got a grip on it in the NHS. So even when people are pointing out problems or want to point out problems, they are faced with multiple challenges. And we have characterised this in terms of understanding what are voiceable concerns, and we have shown that voice failure is especially likely to occur when it involves blaming or criticising others, when it threatens relationships, harmony or loyalty, when it lacks plausibility or is based on uncertain or confidential information. And the credibility gap is huge here. You're actually much more likely to be heard if you're bringing up something that's believable. If you're bringing up something extraordinary, it's very, very difficult to get a response. At the same time as we have issues to do with voice, we also have voice being subverted. So people using HR and other processes strategically as part of counter moves, claiming that they're whistleblowing, but actually exerting vengeance and using it as a means of making threats. Of course, we have to have ways then of responding to concerns, and I don't think we're always very good at addressing the uncomfortable realities here. Many concerns are valid, but not all. Not all problems are equally well evidenced. There are multiple priorities, there is scarce resource, and some problems just cannot be addressed. So some of these issues are very finely balanced. But what is clear is that this transgressive behaviour issue is particularly difficult. We don't have good ways of dealing with cultural and team-based issues. Everything is set up to focus on individuals. Patient safety systems are set up with an explicit remit to avoid blame, and the unintended effect is to make some issues more unvoiceable. Here we do have massive structural issues linked to the legal and institutional frameworks within which organisations have to work, and the fear of employment tribunals driving an awful lot of behaviour. Those risks of institutional secrecy, though, are compounded by organisational behaviour, which you can characterise on a spectrum from comfort seeking through to problem sensing, and organisations that are good at problem sensing generally do much better. Once we've understood problems, we obviously need to develop possible solutions, and that requires an awful lot of structured methods and skill. Here I have some more good news. I've already mentioned the Cambridge Elements series, which is summarising the huge range of structured methods we now have available, everything from supply chain management through to statistical process control through to audit and feedback. all summarised here. And this has been enormously popular with over 260,000 downloads. It's all completely open access. And my wonderful colleagues have been innovating with this. So there's now a micro-learning series, bite-sized content, again, completely free and all peer-reviewed by NHS staff. And we're expanding that all the time. Again, extremely popular. So very important that we have these structured methods for doing improvement. On the ground, local improvement efforts are variably effective. And we see this because when you look at what is happening with local improvement efforts, for example, in surgery, they're not all well designed and not all well executed, and they don't result in improvement. We have ongoing difficulties in demonstrating that QI methods, broadly conceived, do result in reliably in the change that we're seeking. The good news is that there are things we can do to make that local improvement better. We've built 5 principles that you would use to inform surgical quality improvement. And in the last couple of months, we've used participatory methods to consensus build this framework to support small-scale improvement, which is, again, a highly structured approach laid out very clearly to guide you through how you would do local improvement. But local improvement efforts are only part of the answer. We have a current situation where the incentives favour small individual improvement projects, and unfortunately they often lead to reinvention, waste and suboptimal solutions. They are poorly coordinated and curated. They may be very frustrated for the people doing them, especially for resident doctors. They're rarely published and poorly reported, and there's unclear evidence of benefit for a lot of them. One particular problem is solution development. When we've looked at what happens when local organisations try to come up with solutions to safety problems, they tend to be weak and they can introduce system-level problems. And this is because we have not yet realised the benefits of a national system and not sufficiently grasped the challenge that without large-scale coordination, massive waste is a huge risk. I'll give you an example, which is to do with failure to rescue. We know that a large proportion of preventable deaths in hospital, this is where the figure that there are 12,000 avoidable deaths a year in English hospitals comes from. The solution to this is track and trigger systems. So you're tracking the patients and identifying them and responding if they deteriorate. When early warning scores were first introduced for acute illness, it was done at local level. Every single trust came up with their own way of doing it. That was a huge wasted effort. We got massive unwarranted variation, and it wasn't until 2017 that we had a national system mandated. In the meantime, a lot of destandardisation had occurred. Same pattern has emerged with paediatric early warning scores, where the multiple different scoring systems, and they actually score in completely opposite ways in one single city that I could name. Again, that problem was not sorted out until 2023 with the advent of a national paediatric early warning score. Obstetric early warning scores, we had until very recently 147 different scoring systems and escalation policies. Massive variation in what was considered to be a fever. Over 40 was considered not to be a fever by 6 of the hospitals in this. The thresholds and the nature of the required clinical response. So this is not helpful. This is pointing people in different directions and creating risks as people move across the system. This was a problem not sorted out until 2024. So we're generating massive waste, reinventing wheels and not making the progress that we need to. So the question that we have to be asking is, what can we do once and how can we do it well? But where we have national direction, it is not always helpful. We have way too many poorly supported, poorly designed top-down directives. No shortage of recommendations. In fact, we have an extraordinary number of recommendations every year from multiple sources. I spoke to one clinical director who had 904 actions on her list, but the MS&I generated over 4,000 recommendations alone. So this is not a way we can move forward in any kind of sensible way, and it creates the problem we've described as priority thickets. So much being asked that the organisation cannot see a line of sight through, and the only solution that's offered seems to be to just grow more hands. A similar challenge is now emerging with innovations. where again we have an enormous number of innovations and solutions seeking to penetrate the NHS, but an enormous amount of effort going into things that never ever get implemented. We have, for example, multiple clinical prediction models, 606 for COVID-19 alone, many of them at risk of bias, but basically far too many and a lot of them not any good. Most of them are never implemented. The figures are about 3% and unclear evidence of benefit where they are. All kinds of problems with the underlying studies, but nonetheless a strong tendency towards hype and over-optimism, at the same time as many of these interventions have discriminatory effects and have not adequately accounted for diversity of population or may indeed produce more inequalities. Too many of these solutions never get implemented because basically they are not designed as elements of socio-technical systems. The key people have not been engaged throughout the programme life cycle, and the implementation strategy has not been co-designed with the target users. So all that work that you need to engineer the intervention into the work systems just doesn't happen. And the time that's going to be required of staff to do the work isn't accounted for. This study suggested that it takes about 27 hours a day to deliver all general practice care to be guideline compliant. And then we wonder why it's hard to get new things to happen. But also important is the social and emotional work of doing this kind of stuff. The change is never just technical, it also requires an awful lot of working with people. We're now sadly beginning to see exactly the same problems play out. This paper by colleagues has identified that risk assessment in primary care, for example, is encountering exactly these problems, needs to account for people, for risk, system and design. And the result is we're getting this huge gap between what is seeking to penetrate the NHS and what is actually possible to do. And exactly the same problems are now playing out in the AI era. So we're having déjà vu all over again. It's exactly the same pattern. So we have to do better at finding solutions and improving implementation. And I come back to what can we do once and how do we do it well. One of the most enjoyable projects we've done in recent years was a collaboration with the Health Foundation to develop a framework for big programmes in health and healthcare. This built on a huge amount of learning, including government reports in areas well outside health over many years. And one of the key bits of learning from that is the importance of understanding the things as a life cycle, that there aren't interventions, there are things that happen. And one of the things that is most important in getting all of this right is high quality upfront design and planning, participation and sound evaluation. So you have to get that front end right. And that means going for scale from the start and combining rigour with participation. It also means addressing very familiar problems like the toothbrush problem, which is the problem that everyone wants one, but nobody wants to use anyone else's. And the way around that is to forget that there is a top-down, bottom-up duality, that there are things we can do together. A lot of what we've been doing in this institute over the last decade has been working on co-design methods, so working with people who use services and working with those who work in them, and trying to build collaborative infrastructures so we can do that better. And I'm going to talk you through now what that looks like. And the first thing is to know what good looks like. And this is surprisingly challenging sometimes, but we have a large literature on what's sometimes called positive deviance. And this basically suggests that if we can identify the high performers and figure out what they're doing and scaling it, we can make a lot of progress. And this is important because we've mentioned maternity care a few times, but the top 20% of maternity units perform way better than the rest. And if we could scale what they're doing, it would make a huge difference very quickly. The good news is that we can work out how to do this. We can characterise what is going on in the top performing units. And we've done this for maternity care. We've enhanced that further for CQC, and it's now clear what it is that good needs to look like for maternity units. In a collaboration with the London School of Hygiene and the National Cancer Audits, we're now going to be using similar kinds of methods to address cancer treatment delays, a project that's mentioned in the national plan and that is going to be making use of positive deviance techniques and at-scale participation, all based on the principle that the solutions might already exist And if they do exist in the system, they're likely to be feasible and acceptable, but we have to identify the high performers, figure out what they're doing, turn it into something everyone can do, and support that all with large-scale collaboration. And we're going to be doing some of that online through a community platform. You have to use structured methods to co-design the solution, and we've been codifying these methods progressively over the years, and I'm going to illustrate this using the example of the Avoiding Brain Injury in Childbirth programme that we addressed to develop two of the major contributors to harm resulting in clinical negligence claims. So you start with identifying the best available evidence, but understand you have to make that meaningful. We have known for some time that there is a set of risk factors that you can monitor during a labour, but we also know that they're not necessarily meaningful for the stakeholders. So what we did with this project was co-design the whole process with staff and patients. When we went out to consultation, the staff said they accepted the risk factors, but they said 4 of the 8 needed to be more clearly designed, so they helped us consensus build what they are and therefore were acceptable. The next thing is to optimise the work system using human factors and ergonomics principles. Very pleased to say that the next edition to come out of our series is going to be on human factors and ergonomics. And this is highly skilled work where you're working out what the work system is, the processes, and you can purposefully design and optimise them so they facilitate the right thing at the right time. You can use the similar kinds of principles so you're improving technical proficiency and teamwork, which is often key to what you need to do to improve care. You have to design communication highly intentionally, and you have to do that with patients, and you have to really listen to what's important to them so that inclusive, respectful communication principles and techniques can be co-designed and engineered in. And again, we've been codifying what that looks like through principles for patient and public involvement. Crucially, then, you have to prototype and test, and we've had very good experience with using clinical simulations, using real teams, real clinical scenarios, and then you can work out what needs to improve. But also, you have to design for implementation from the start. So you have to start with collaboration at the beginning and keep that going all the way through. And this has been part of the success of the ABC programme. It's been adopted as national guidance. It's got an at-scale strategy for implementation using this highly efficient train-the-trainer model. The national rollout was announced in May of 2025. It's now underway across England. It is regularly mentioned in the news when there is a tragedy, and I'm delighted to say that my own grandson benefited from the ABC programme when born in January, so that was a very personal endorsement of it. Can we do the same for non-clinical work? We absolutely can. We can use these kinds of techniques to address some of the really big challenges that we have in management, in operations and systems. The good news is that we can design solutions to things like voice, we can design solutions to transgressive behaviour, and we have done this very successfully in a hospital in the US. But we do have structural problems that have to be addressed in the UK, and that is this wider institutional context of employment law and professional regulation. My final section then is going to be about evaluation. It's just critical that we're working out what works, what doesn't, and why, and in fact more than that. We don't have enough evaluation in the NHS, and it's not always done well. There's a significant problem of under-evaluation. When we looked at over 50 maternity improvement initiatives over more than a decade, only 15 of them had been evaluated, and most of those programmes demonstrated significant weaknesses. The good news is that when you do this kind of evaluation well and it's taken seriously, it can result in improvement. We've recently completed an evaluation of the maternity incentive scheme run by NHS Resolution, and that has already resulted in change, including a reduction in the number of safety actions, reduced over-specification of requirements, and a strengthened approach to governance and oversight. But this question of evaluation is now massively important with the volume of innovations and initiatives looking to make an impact on the NHS. We cannot afford to squander the scarce resource of the NHS. We have to have good evidence to support improvements in productivity and benefit to patients. This is particularly important when it comes to the multiple AI interventions that we're seeing. A model that performs well in the lab or in silico is not necessarily is a necessary but not sufficient condition. Many of the interventions we're seeing lack a good front end. So this gap between what is possible or what is looked for and what is actually happening is growing. Characteristic problems include going to scale without the intervention being optimized. We saw remote technology for virtual wards for people with frailty being widely promoted, but very low adoption, less than 40%. And this is because the solution was not suited to how to the problem. And this is because it was an intervention in a socio-technical system that had not understood the range of things that need to be done for that to be something that is useful to the clinicians and beneficial to the patients. Another problem is going to scale without an implementation strategy and without readiness in organisations being optimised. Electronic patient records promise improved productivity, but our friends in the Health Foundation have found it can make it harder to work across the NHS. There isn't enough real-time support, there's limited opportunities to feed back, and there are gaps in training. Going to scale without a sound evaluation plan is a continuing problem. In the 115 local evaluations of the Vanguard programme, there was no standardised reporting and everything was small scale and context specific, so you can't get an overall sense. So these familiar problems of fragmentation, poor coordination and waste are persistent. At the same time, massively overblown claims are being made about the benefits of technology. The 10-year plan mentions ambient voice technology 11 times. It claims that if this could be introduced, it would be the equivalent of over 2,000 GPs. These extraordinary claims, billions being saved by, have been repeated to the extent that they are now driving policy. But much of that is based on really very poor quality underlying studies. And the reality is that we don't have the methods to determine return on investment because of the problem of not being able to assess time use in the NHS. This institute is currently doing 2 evaluations of the impact of ABT on professional time use, one in general practice, one in hospital care. The story of adoption and implementation is far more complex than we might have been made to believe, but also clear is that doing these kinds of evaluations is very, very challenging. So if we're going to make claims about improvements in efficiency, cost saving and benefits to patients, they have to be evaluated in the real and rigorously. And this is important because this American study showed that if you introduce AI prioritization, you do not reduce the median time from chest X-ray to diagnosis. And that's because it has to be designed and evaluated as a component of a socio-technical system. And that it takes investment in infrastructure, workforce, not just AI. So optimizing one component, like the shoes of the marathon runner, is no way to optimize the system overall. So inserting and evaluating AI without work system optimization is massively wasteful. We just can't keep doing this. And it's particularly important because when you examine implementation in different organizations, it too is highly variable. This decision support system for thrombectomy produced a very welcome increase. Decision support system for stroke produced a very welcome increase in rates of thrombectomy, but it wasn't possible to implement it effectively in all settings in which it was tried. So we have to have a life cycle approach. We have to be thinking about risk over a life cycle of an innovation. The SOTEC framework helps alert us to all kinds of things that can go wrong when we're using innovation. But even for the shiniest things, we're often straight back to really mundane objects, tasks, roles, work system design, training, understanding organisation, capabilities, capacity, culture, underlying infrastructure. If we don't remember that, we have forgotten how to improve. Also important is that we have to go beyond effectiveness, cost and safety. Things like the social license and equity remain real responsibilities. And we see this in other areas like facial recognition. We have to have not just epistemic integrity and responsibility, but we have to have ethically responsible and legally responsible evaluations. We have to be constantly looking at issues of fairness and equity, and we have to look at what it is that is important to patients and staff and figure out how we build trust and how we manage that. The huge volume of solutions is exceeding evaluative capacity and the ability of trust to make good decisions. There is no sign that the pace of innovation is being matched by the quality and pace of evaluation. So I'm going to conclude by saying how we do better on evaluation. The drug development model has many advantages, and one of them is its emphasis on testing before you go into humans. But it represents things as a straight line, and that's not how the world works. The MRC NIHR framework for evaluating complex interventions takes us further, and it understands that interventions play out in complex adaptive systems. And the work that's been done by NIHR has given us comfort that some of this can be done both rapidly and with rigour. So what might better look like? I think better would look like designing implementation and evaluation together. So we have evaluative implementation, doing much more inclusive engagement and using online techniques over a life cycle, building standing infrastructure, using techniques like silent testing, modelling and simulation before going live, testing in one ready site and then in more diverse sites, informing decisions about scalability and agreeing on governance and ethical frameworks. So this is going to require a much more cyclical approach while we work out, can this work? Is it non-inferior? Is there enough return on investment? Can we get it to scale? And can we do all of this in a speedy way? To do that, we're going to need big coordinated programs, not fragmented, isolated projects. We need this commitment to understanding and identifying unintended consequences, discrimination and bias and safety risk over a life cycle. We have to combine rigour with participation. We have to engage people from the start and throughout. And an example of this is the platform we have built for ambient voice innovation and development. Has over 1,000 users and has also shown us that when you look at what people are asking about, they have multiple concerns that have to be addressed. And we can tell this from the way they're engaging on this platform. They're interested in practical implementation, all the things we've been talking about, work system design, tasks, roles, procurement, training, environmental considerations, patient acceptability. This isn't just boring stuff. And it's not always dealt with actually in evaluations, but this is the difference between something working and not working. We need to build more standing infrastructure. That's going to include a network of sites that could be mobilised for evaluation. We need to build networks of patients and professionals and engage them properly in these big programmes, not just small ones. We need to be using more techniques like silent testing. So we're testing things using at the same time as without intervening. And the importance of this was demonstrated by a recent study showing that AI does a worse job than you might expect of detecting nasogastric true position. We need to be using more simulation, and that it means that we can figure out what happens when you try to put one of these in and what needs to happen for it to work in a safe way. And we're beginning to see frameworks for this emerging. Rapid cycle testing and optimization, starting in ready sites, is going to be a key here, and we're beginning to see ways that we can use principles of readiness to test whether something can work at all. And then using these principles of positive deviance, we can figure out what they're doing in sites that get it to work and scale it. We need to monitor using agreed data items and plan for the long term. So we're watching what's happening, and we can be attentive to unintended consequences. That's going to mean facilitating easy, quick feedback from patients and staff in real time. And again, we are seeing encouraging examples so that it is possible to do this. If it works, then we can make a decision on scaling, trial or long-term surveillance or observational studies. Can we do it for non-clinical work too? We absolutely can, and the same principles apply. So, to conclude, can improvement and innovation save the NHS? Well, nothing else is going to. But we do have to build these three capabilities. We have to understand problems, we need to develop possible solutions, we need to evaluate them. Jennifer Dixon, great name, CEO of the Health Foundation, has said we've constantly swung backwards and forwards on these key dualities between national direction, local autonomy, political versus operational direction at the top level. We have to do better when large-scale coordination is the right solution. There are many, many issues that benefit from this whole sector coordination and action. We have to be much more intentional about the strengths of the NHS as a national system. We have to develop those three capabilities. If we're going to save the NHS, now is the time to reimagine implementation, engagement and evaluation. I'm just going to conclude with a few thank yous. One is to Downing College for hosting us this evening in these beautiful surroundings. The advisory committees to this institute and their chairs do a fantastic job for us. Health Foundation for supporting us in their ongoing partnership. Colleagues at the Department of Public Health and Primary Care, the Clinical School and the University. The fantastic team at this institute who I'm just incredibly proud of, and it's a joy to work with them every single day. But most importantly, the staff and patients of the NHS, which is who we work for. Thank you very much.